Thank you for the introduction and the invitation to speak today. As we are all aware, the incidence of kidney cancer has been increasing steadily since the 1970s, in part due to more prevalent abdominal imaging, with an estimated 300,000 people diagnosed with kidney cancer globally each year. The majority are comprised of small renal masses, less than 4 centimeters in size. Within this group of small renal masses, approximately 20% are benign, and many malignant lesions have a low risk of progression. To assist with risk stratification, several groups, including our colleagues in Toronto, have spoken at length in recent years advocating for greater utilization of renal mass biopsy in small renal masses, to the point where you begin to wonder if they own shares in Nike or they just watched the Shia LaBeouf meme one too many times. On that note, I thought it would be worthwhile to review the imaging of small renal masses with respect to attempting to differentiate between malignant and benign. Discuss the literature on the accuracy of renal mass biopsies and highlight the pathologic and radiologic challenges. We will have Dr. Brian Skinnider, our uropathologist, join us as well. And I'll highlight the potential risks involved and end with how I incorporate renal mass biopsy in the context of shared patient decision-making. Let's start with the classic clinical presentation of an incidentally detected small renal mass. What would your differential diagnosis of this renal lesion be? Well, the residents just had their mock OSCEs and in-service exam, so I'm certain that they know this list. But based on imaging characteristics, we're generally able to diagnose upper tract urothelial cancer based on a non-circumscribed central location within the collecting system, or an AML based on the presence of macroscopic fat. As well, based on clinical history of prior malignancy or clinical symptoms of pyelonephritis, the differential diagnosis can be narrowed down relatively quickly from this long list. Now, this is a point I constantly emphasize with our residents. We as urologists need to be comfortable reading our own imaging, particularly CTs. First, we should systematically review the non-contrast phase to assess for macroscopic fat. The attenuation of normal renal cortex typically ranges from 30 to 40 Hounsfield units. A hyperattenuating renal mass usually measures between 40 to 90 Hounsfield units. Lesions with homogeneous, unenhanced density greater than 70 Hounsfield units have been reported to be hemorrhagic cysts more than 99% of the time. Hemorrhagic cysts may also have a density less than 70 Hounsfield units. However, they're best confirmed as non-enhancing lesions with pre- and post-contrast enhanced imaging. A high-density lesion, 40 to 70 Hounsfield units, is most commonly RCSC, but there is overlap with benign lesions. Lesions that appear lower density than the renal cortex include cystic lesions, focal pyelo, abscess, and papillary renal cell cancer. In such cases where clinical history is not informative or may be confounding, MRI may provide more information. The cornerstone of assessment is enhancement, which is defined as an increase of greater than 20 Hounsfield units on contrast enhanced compared to non-contrast images. When an attenuation change falls within 10 to 20 Hounsfield units, this may be attributable to pseudo-enhancement. The phenomenon of pseudo-enhancement is known to be significantly associated with a central location and also masses less than 1 centimeter in size, limiting CT assessment in such cases. In this case, subtraction imaging with MRI may be useful if it's available. As mentioned in the previous slide, MRI can provide additional information with respect to enhancement on subtraction images, particularly for complex cysts or lesions with equivocal enhancement on CT. The detection of bulk fat on MRI is accomplished through T1 weighted imaging with and without fat suppression, or T1 in phase and out of phase imaging using the India ink artifact. However, should note that microscopic fat detected as a loss of signal on out of phase imaging cannot reliably be used to discriminate between lipid poor AMLs and clear cell renal cell cancer, because this may also contain microscopic fat. So like NBA teams, the differential diagnosis of an enhancing small renal mass often comes down to three main players: RCC, Oncocytoma, and a lipid-poor AML. And this remains the most clinically relevant imaging challenge for localized small renal lesions, is distinguishing between RCC and these two benign lesions. Several CT and MRI features have been suggested to differentiate between oncocytoma and RCC. Young et al. Found that a clear cell renal cell cancer was differentiated from oncocytoma with a positive predictive value of 84% using attenuation thresholds of 106 Hounsfield units in the corticomedullary phase, 92 Hounsfield units in the nephrographic phase, and 68 Hounsfield units in the excretory phase. In terms of enhancement pattern, oncocytomas have been reported to demonstrate a segmental inversion pattern in which the degree of enhancement reversed in the nephrographic phase at 120 to 180 seconds compared to the earlier corticomedullary phase at 30 to 40 seconds. But these findings have not been consistently reproducible. Furthermore, a central scar is present in the minority of cases. To date, there is no qualitative or quantitative imaging features that have been shown to reliably diagnose oncocytomas on CT or MRI. Likewise, lipid-poor AML cannot be reliably distinguished from RCC on imaging. In several small studies, minimal fat AMLs have been described to demonstrate homogeneous enhancement. Yang and colleagues examined the potentially predictive imaging variables and found that high density on non-contrast images was the only examined variable that consistently and significantly differentiated minimal fat AMLs from RCC. Hyman et al. Found that low T2 signal was the only imaging feature aside from small size that predicted minimal fat AML in multivariate logistic regression. However, as displayed by our previous MRI diagnostic algorithm, minimal fat AML can present in a variety of imaging characteristics. Given that CT or MRI imaging alone cannot differentiate between malignant and benign, can additional clinical information assist us in predicting cancer and even grade? Well, several studies have developed algorithms with the aim of predicting malignant versus benign pathology based on covariates such as age, gender, lesion size, smoking history, and symptom classification. However, the concordance index ranged from 0.56, which is only slightly better than a flip of a coin, to 0.64. In a single center retrospective study of patients undergoing partial or radical nephrectomy, integration of lesion anatomy using the renal nephrometry score with age and gender resulted in a predictive model with an area under the curve of 0.76 for malignancy versus benign and an AUC of 0.73 for tumor grade. It's found that the nephrometry score correlated with both tumor grade and histology, such that small endophytic non-hilar tumors were more likely to represent benign pathology. Conversely, large interpolar and hilar tumors were more often represented high-grade cancers. The resulting nomogram from data at Fox Chase Cancer Center offers a useful tool for preoperative prediction of tumor histology and grade. However, a lack of external validation was a limitation of the study, as well as selection bias. A Korean study of over 1,000 patients, of which 90% were RCC and almost 40% were high grade, aimed to externally validate the renal nephrometry score nomogram. They found that the predictive value of malignancy model was similar to the model development cohort. The AUC was 0.722. However, the predictive value of the high-grade model was inferior and close to another coin flip, with an AUC of 0.574. Although these nomograms weren't very good, i.e. the AUC wasn't 0.8 or 0.8 to 0.9, nor excellent, an AUC of 0.9 to 1, these studies highlight a clinical observation that I've noticed in my own practice, in that large interpolar and hilar tumors more often represented high. We'll discuss this later in the presentation, but particularly in these lesions that are anteriorly located, they often are not amenable to renal mass biopsy. there can be a natural inclination to potentially manage these lesions conservatively. However, I've noticed that these lesions are most likely to be high grade, upstaged with segmental renal vein or renal sinus fat involvement, or progress rapidly. For instance, this is a case of a 75-year-old who had a 3 centimeter left anterior hilar lesion that in retrospective review of a CT almost a decade prior was 6 millimeters. We elected for a laparoscopic partial nephrectomy, but his perinephric fat was extremely adherent. So we electively converted to a laparoscopic radical nephrectomy. Final pathology showed grade 4 pathological T3A renal cell cancer with negative margins. Unfortunately, within a year, he developed bone mets with a pathological femoral fracture. We've demonstrated that imaging and nomograms alone cannot completely predict malignancy versus benign lesions, which leads us to the main topic of our presentation today, renal mass biopsy. According to the most recent AUA renal mass guidelines, updated in 2017, and a Canadian consensus statement in 2019, renal mass biopsy should be performed if you suspect a pathology other than RCC that may require management, such as lymphoma, metastatic lesion, infection, or upper tract urothelial cancer, although generally diagnostic uteroscopy is preferred over percutaneous renal mass. Also, if there is a suspected de novo metastatic renal cell cancer, in which case either a renal mass biopsy or a biopsy of the metastatic lesions can be undertaken to obtain a tissue diagnosis for contemplation of systemic therapy and or eligibility for clinical trials. Prior to or at the time of RFA or cryoablation. And lastly, but most importantly, as this is the main focus of our discussion today, when the results will alter patient management. For a renal mass biopsy, you'll need someone to hit the target and someone to tell you what it is. And so ultrasound or CT guidance is generally utilized, and coaxial sheaths are favored to limit the risk of seeding. Based on meta-analysis data, core biopsies are favored over fine needle aspirations or FNA. However, FNA may be performed in combination with core biopsies in selected cases. A potential advantage of FNA is that it allows for intra-procedural assessment of the cytologic specimen, which can be potentially confirm the appropriate location of the guiding cannula and increase the diagnostic yield of subsequent core biopsies. Before we dive into the literature on the accuracy of renal mass biopsies, remember that it is a diagnostic test with results classified in the classic 2x2 table. So a true biopsy is where both biopsy and the surgical pathology show renal cancer. A true negative is where both biopsy and the surgical pathology are benign. As we'll soon review, both the true and false negative rate are not clearly known, as most patients with a negative biopsy do not undergo surgery and therefore have no final or reference pathology. As a result, calculation of sensitivity and specificity is limited. When the true and false negative rate is unknown, this leads to a differential verification bias, since this set of patients with a negative renal mass biopsy do not undergo the reference standard of final surgical pathology, but instead are often verified with surrogate tests such as imaging. The other major type of bias encountered in these studies assessing diagnostic accuracy is selection bias, as eligible patients are often not enrolled consecutively or randomly. With these limitations and biases in mind, let's examine the two largest systematic reviews in the literature, both published in 2016, one in the European Urology and one in Journal of Urology. The first systematic review published in European Urology includes studies on percutaneous renal mass biopsy from 1946 to 2014. Over about 1,500 studies were identified, of which 57 were included in the systematic review with over 5,000 patients. This is a portion of table 1. Apologize for the small print, but this lists the main characteristics of each study. Due to the earlier era included in the systematic review, the lesion size is generally larger than more contemporary studies. Some of these studies had a lesion size of 9.2, 4.1, 7.3 centimeters. Overall, there's a high risk of bias across the studies. Only 5 were prospective, as a majority were retrospective single-center case series. As well, there were concerns about differential verification bias because surgical pathology as a reference standard in all patients was only available in 11 studies, as the majority of the studies only had a proportion, a median of 56% of pathology available. The overall diagnostic rate was 92%, with a non-diagnostic biopsy rate ranging between 0 to 22.6%. Figure 3 here shows a forest plot of the 17 studies assessing core biopsy accuracy. The estimates for sensitivity and specificity of diagnostic core biopsies based on bivariate analysis were 99.1 and 99.7% respectively. However, as we discussed previously, the true sensitivity and specificity cannot be calculated without the knowledge of the true and false negatives. There are 14 studies that reported concordance of tumor histotype between the renal mass biopsy and surgical pathology, with a median concordance rate of 90.3%. 7 studies allowed the analysis of agreement between grade on biopsy and surgical. The median concordance rate was 62.5% using the 4-tier grading system, so i.e. grades 1, 2, 3, 4, and 87% using the more simplified 2-tier approach, low versus high grade system. As expected, your concordance rate is going to be higher when a simplified 2-tiered system is adopted. The second systematic review, published in the Journal of Urology, searched articles in a more contemporary era between 1997 to 2015. Nearly 21,000 citations were identified, of which 20 studies with 2,900 patients and just over 3,000 biopsies were included in the study. The overall non-diagnostic rate was 14%, with 90% of those undergoing surgery found to have malignancy. A repeat biopsy led to a diagnosis in about 80% of patients. Core biopsy, again, was shown to be highly sensitive at 97.5% and specific at 96.2% when a diagnostic result was obtained. Histologic RCC subtype concordance was again generally high at more than 90%. However, with respect to grading, 12 studies provided data in which nearly 2/3 of biopsy positive lesions were assigned a grade. The majority were low grade. However, the concordance between renal mass biopsy and surgical pathology varied between almost 50 to 75%. Interestingly, 10 studies reported upgrading from low grade to high grade on surgical pathology in a median of 16%. Similar to the first systematic review, the overall strength of evidence is low to moderate. However, the results highlight a major challenge with respect to the accuracy of renal mass biopsy. Let's look at our 2x2 table again. So among 1,710 malignant biopsies, 965 cases proceeded to surgery with available pathology, among which 2 were false positives for a percentage of 0.21%. However, at over 80%, the majority of patients did not undergo surgery after a benign biopsy. So as a result, only 79 of the 468 benign biopsies actually had surgical pathology available. So the real true negative and false negative rates are unknown. There were 29 false negatives, or put in another way, 36.7% if the denominator is 79. In other words, among patients who underwent surgery with a negative biopsy, about 1/3 ended up having cancer on final surgical pathology. Even if you recalculate things, in the unlikely occurrence that the remaining 389 benign renal mass biopsies were all benign on surgical pathology, the false negative rate would be about 6.2%. So what is the major reason for a substantial false negative rate? Well, it's the pathologic challenge of oncocytoma. Although oncocytic or eosinophilic areas can be seen in almost any renal neoplasm, there are a few entities which may closely resemble oncocytoma throughout the majority of the mass. Broadly, these are neoplasms with a solid or nested pattern of growth and abundant eosinophilic cytoplasm. A few entities most likely to mimic oncocytoma include chromophobe RCC, which has the most morphologic overlap, especially with the eosinophilic variant, hybrid oncocytoma chromophobe, SDH deficient RCC, papillary RCC with eosinophilic cells, or a pecoma. So this is a situation where seeing the entire picture or the surgical pathology provides a more certain diagnosis compared to relying on a smaller sample. On that note, I welcome our GU pathologist, Dr. Brian Skinnider, to discuss lesion heterogeneity.
Thank you, Mike. Let me just share my slide. So can everybody see the histology?
Yes.
Needle biopsies. When we see needle biopsies for renal masses, most of them we can make a diagnosis. One of the issues for very small lesions is simply hitting the lesion. But if there's lesional tissue in the core, we can make a diagnosis in most cases, say 80 to 90%. So on the left here we have nests of clear cells. This is a pretty straightforward clear cell renal cell carcinoma. On the right we have a papillary tumor. So this would be easily diagnosed as a papillary renal cell carcinoma. One of the problems with renal masses is the larger they are, the more heterogeneous they can be. And certainly tumors around, around the 4 centimeter size can definitely be heterogeneous. So here, if we see the entire tumor, we can identify this as a clear cell renal cell carcinoma based on the left side. But here we have a higher grade area, which would probably not be identified on needle biopsy. So if you have a needle biopsy that hits this area, you can make a diagnosis of clear cell renal cell carcinoma pretty easily. Here, if the needle biopsy hits this area, this would be much more challenging. It certainly doesn't look like a clear cell renal cell carcinoma just on morphology. So here's a similar case. This was a needle biopsy, a fairly eosinophilic look to it, although there is some starting to have some clearing of the cytoplasm. The differential diagnosis would be pretty broad. This could even be a fat poor angiomyolipoma. So one of the first things is we do a PAX8 stain to confirm that this is a renal epithelial lesion. And further immunohistochemical stains for such cases can be quite helpful. So here we have strong staining for our carbonic anhydrase 9, which really supports that this is a clear cell renal cell carcinoma. Some of the other stains, so CK7 would be more in chromophobe or papillary carcinoma. C-KIT would be expressed in most chromophobe and oncocytomas. So even though the morphology is not particularly typical, this would be diagnosed as a clear cell renal cell carcinoma. But as Mike mentioned, oncocytic neoplasms on needle biopsies and often on resection specimens cause the most difficulty. The problem is that many renal tumors can have oncocytic cytoplasm. So the classic differential is chromophobe renal cell carcinoma versus oncocytoma. But as we've seen, clear cell renal cell carcinoma can have eosinophilic areas, as well as papillary tumors and epithelioid angiomyolipoma. The problem with eosinophilic chromophobe RCC and oncocytoma is that chromophobe renal cell carcinomas can have areas that very closely resemble oncocytoma. And the other issue is there is an expanding list of new oncocytic renal tumors. Within the last few years, a low-grade oncocytic tumor has been described that doesn't fit either with chromophobe or oncocytoma. And then there are hybrid chromophobe and oncocytic tumors in the Birt-Hogg-Dubé syndrome. So here is a eosinophilic tumor from a partial nephrectomy, and you can see that there is variability in the appearance. So more on the left side, you see there is lots of eosinophilia, but there are areas with more light staining cells, whereas on the right side, it's more densely eosinophilic. So if a needle biopsy hits this area, this morphology is classic for chromophobe renal cell carcinoma. It would be an easy diagnosis to make on a needle biopsy. But if the needle biopsy hits this area, my first thought would definitely be oncocytoma. It's not an obvious chromophobe renal cell carcinoma. So when we get needle biopsies with oncocytic neoplasms, we always kind of hedge a little bit. Here's an example with nests of densely eosinophilic tumor cells in a loose edematous stroma. If the tumor looks like this throughout the entire tumor, then this would be an oncocytoma. But we can never say with 100% certainty that this is a chromophobe, that this isn't a chromophobe carcinoma with areas resembling an oncocytoma. I think if it's a very small lesion and it looks like this, it's almost certainly an oncocytoma, but larger lesions can definitely have that heterogeneity that makes definitive diagnosis difficult. For the differential diagnosis between chromophobe and oncocytoma, immunohistochemistry can sometimes help. Cytokeratin 7 is the main stain that we would use. Oncocytomas are negative or very focally positive for cytokeratin 7. So here you just have a few scattered positive cells. The problem is that about a quarter of chromophobe carcinomas, so most chromophobe carcinomas will be diffusely positive for cytokeratin 7, but the problem is that about a quarter of them will be negative. So if you have a negative stain, it really doesn't help in that differential diagnosis. So in closing for my section, needle biopsies are excellent at distinguishing malignant from benign in most cases. When you incorporate immunohistochemistry, over 90% of RCCs can be correctly subtyped. But as mentioned, oncocytic renal tumors can be very difficult to classify on needle biopsies. Thank you.
Great. Well, thank you, Brian, for your insightful comments, as well as these great examples of the pathologic challenges that are inherent with these biopsies. Moving on to a discussion of the safety of renal mass biopsy. Based on the two large systematic reviews, the overall risk of complications was low, with the majority of complications, not surprisingly, related to bleeding. However, with respect to tumor seeding, the initial studies in the 1990s and 2000s with routine histologic assessment of the perinephric fat surrounding the tumor after surgical resection demonstrated no evidence of seeding. There were several case reports that came up, and they attributed these seeding events to a lack of using a coaxial sheath, larger gauge needles, or multiple punctures of the lesion. So it's been generally accepted that tumor seeding along the needle tract is anecdotal, but several more cases have been reported recently. This UK tertiary referral center reported 7 patients with tumor tract seeding on frontal pathology after surgical resection of RCC between 2014 and 2017. One of these patients subsequently developed a local tumor recurrence at the site of the previous biopsy. This concept of tumor tract seeding within the perinephric fat may manifest as pathologic upstaging. In a review of the National Cancer Database from 2010 to 2013, approximately 24,000 patients underwent surgery for clinical T1A lesions. There was pathologic upstaging to T3A perinephric fat involvement occurring in 1.2%. This rate of upstaging was 1.1% in the no biopsy group, compared to 2.1% in patients who underwent renal mass biopsy. In other words, renal mass biopsy was associated with a 1% increased rate of upstaging to perinephric fat involvement. This effect is small and with unclear clinical significance, as the impact on overall survival and cancer-specific outcomes are unknown. Another recent case series observed needle tract tumor seeding to the perinephric tissue in 6 RCC cases. The needle tract seeding was exclusively observed in papillary subtype that were unifocal, small-sized, confined to the kidney, and had type 1 features. There was no recurrence or metastasis observed in these 6 cases in short-term follow-up. To date, there are less than 30 reported cases in the literature, and almost all are papillary subtype. Perhaps this is due to the friability of papillary RCC, which can be seen when the lesion will ooze out of the capsule, kind of like toothpaste under pressure. You may have seen this if when you extract the specimen and it fractures within the specimen bag when you're trying to extract it through a really small port site. That's when you'd commonly see this phenomenon. My own personal reflections of the risk of renal mass biopsy, I've seen tumor tract seeding myself in 2 cases, and so it's likely that it's underreported. After these 2 cases, I now make an effort to try to keep the perinephric fat overlying the lesion intact with the specimen, especially if papillary RCC was suggested on renal mass biopsy. Fortunately, I've not had any Clavian 2 or higher complications on renal mass biopsy, likely due to a highly selective approach of avoiding renal mass biopsy in lesions that are close proximity to hilar or segmental. Lastly, I've seen several cases of perinephric fibrosis after a renal or a renal mass biopsy. This one case in particular stands out. This was a 53-year-old gentleman who was diabetic, who had chronic kidney disease, eGFR of 29 mils per minute. He was obese, BMI of 45, and he had this right 7 centimeter upper pole renal mass with a renal nephropathy score of 8x. And as you can see here, there's a small foci of what appears to be macroscopic fat in the superior aspect of the lesion. And so given the higher stakes and the technical challenge of a nephron sparing surgery here, as well as the diagnostic consideration of a lipid poor AML, I wanted to get a renal mass biopsy. And so the first renal mass biopsy was aborted by radiology. I think they took a look at him and said, I don't want to do it. The second ultrasound guided renal mass biopsy showed grade 2 RCC, although I was kind of really hoping that it would be AML. But nonetheless, we proceeded to a laparoscopic partial nephrectomy. And this turned out to be my one and only case where I needed to have a non-urgent conversion from a laparoscopic to open partial nephrectomy. And that was due to significant perinephric fibrosis of the posterior upper pole where the biopsy tract was. Simply put, I could not mobilize the upper pole laparoscopically. Fortunately, we were able to complete the partial nephrectomy open. It did require an arterial reconstruction repair of the segmental renal artery. The final pathology showed papillary renal cell cancer, grade 3. So there's some upgrading there. Pathological T2A with negative margins. And fortunately, his EGFR remained unchanged post-op. So even though renal mass biopsy helped to guide this patient's management, it ended up making a difficult case even more difficult. With that in mind, after reviewing the literature regarding the accuracy and the risks of renal mass biopsy, let's discuss whether routine renal mass biopsy should be a standard of care to guide the management of small renal masses. Certainly, Toronto has amassed the largest Canadian series on renal mass biopsy, with results similar to 2 previously reviewed systematic reviews. And in comparison to Canadian centers in Quebec and Ontario, with a more selective approach towards renal mass biopsy, a decreased rate of benign final pathology and potential overtreatment has been the argument for adopting routine renal mass biopsy. So in centers with routine renal mass biopsy, where about 63% of patients had a preoperative renal mass biopsy versus 12% in the centers with selective biopsy practice pattern, the rate of benign final pathology was statistically significantly lower at 5% versus 16% in the selective renal mass centers. However, this study was interesting that it highlighted another limitation of renal mass biopsy with respect to its accuracy and tumor grading. As expected, the grade concordance was better using a more simplified 2-tier system of low versus high grade, but still with only 71% concordance. More concerning, however, was that only 40% of the high-grade lesions were correctly graded on renal mass biopsy. As previously discussed during our review of the 2 large systematic reviews, the grade concordance varies particularly if a 4 or 2-tiered grading system is used. The grade concordance between renal mass biopsy and final pathology is limited by intra-observer variability, tumor heterogeneity, and sampling. In fact, intratumoral grade heterogeneity has been reported in 5 to 25% of renal tumors. Its potential impact on biopsy accuracy could be reduced by performing multiple biopsies in different areas of the tumor. Now, with nearly 60% upgrading in this Canadian study, the majority of high-grade tumors would have been classified as low-grade if only renal mass biopsy were used. This shortcoming is especially significant in active surveillance programs that rely on renal mass biopsy to guide treatment decisions. It remains unclear whether grade determined on renal mass biopsy is accurate and reliable enough to serve as a triage tool to identify patients or candidates for active surveillance. As urologists, how should we counsel patients with a small renal mass when we're standing face-to-face, or more likely via Zoom or over? Well, many clinicians remain reluctant to adopt routine renal mass biopsy as a standard of care to guide the management of small renal masses. Several frequently cited concerns include variable concordance of renal mass biopsy and surgical pathology, a lack of evidence supporting the biopsy accuracy outside centers with experience, a risk of obtaining a non-diagnostic biopsy, and the idea that the biopsy will not alter management. We've already reviewed the data on variable tumor and grade concordance. Let's look at some of the other concerns. Now, we discussed what is required for a renal mass biopsy, and you really have to look at who your teammates are. A team of physicians with experience performing and analyzing the results of renal mass biopsies is important. Centers with experienced radiologists to perform the renal mass biopsies and a genital urinary pathologist to review the tissue have consistently reported high diagnostic rates. not known if these results can be replicated in lower volume centers, and variability in diagnostic accuracy has been shown to exist between centers. Therefore, individuals should review their own center's experience. A related challenge of renal mass biopsy is the non-diagnostic result, which ranges between 10 to 20% in the literature. A relevant proportion of non-diagnostic biopsies are in fact failed biopsies due to technical limitations, such as the use of suboptimal technique, needle type, or image guidance, and or to the intrinsic challenge of the procedure itself, targeting a mass in an organ that moves with respiration. In this study of over 500 renal mass biopsies, with a non-diagnostic rate of 17% in those with small renal masses, independent predictors of a non-diagnostic biopsy in lesions less than 4 centimeters included those with cystic features, enhancement less than 20 Hantu units, smaller lesions, and those with a skin to tumor distance greater than 13 centimeters. So the main guiding principle in the AUA and CUA guidelines is to proceed with biopsy in whom the results will affect their management. And nothing tests this resolve more than a non-diagnostic biopsy, particularly if this occurs on a repeat one. Most of us have been in this dilemma. Should I order a second or a third renal mass biopsy? Will it change my management? Well, really, this is a question we needed to ask ourselves before the first non-diagnostic result. Now, several factors need to be considered during patient consultation for a small renal mass, including individual patient characteristics or considerations and lesion characteristics. These factors are associated with the probability of renal malignancy, their life expectancy, the diagnostic performance of renal mass biopsy, and the probability of biopsy or treatment-related events. And so, although patient selection is a key component in minimizing adverse events, as urologists, we also have to look in the mirror to reflect on our own skills, our experiences, and biases as surgeons in treating these patients. We all understand that our interventions can cause morbidity and mortality, and only through self-reflection will we be able to adequately counsel our patients regarding what are the true risks and benefits of treatment options. So looking at my own series, it's no surprise that my bias leans towards laparoscopic partial for the management of renal mass. And in over 400 lap partials for lesions of all sizes and stages, unfortunately, the overall complication rate has been low. In fact, when you take into account that the majority of these patients with Clavian 2 to 4 complications had lesions greater than 4 centimeters or higher stage lesions, the complication rate of those with small renal masses undergoing lap partial was actually quite similar to the renal mass biopsy bleeding complications that we talked about a couple of slides ago. Now, most importantly, I've been blessed to have an amazing team of residents, perioperative anesthetists, and interventional radiologists to provide timely care, particularly in the rare times when an urgent angioembolization is required. As a result, none of these Clavian 3 or 4 patients had a permanent loss of kidney function or required nephrectomy. So incorporating all of these factors discussed, I basically adopt a highly selective approach to renal mass biopsy and estimate that I order about a renal mass biopsy in about 10% of my patients with small renal masses. This is generally because I prefer upfront partial nephrectomy, as surgical pathology is the best pathology, and fortunately it's been associated with low morbidity. This way, I acknowledge that there's some overtreatment, but this is to obtain pathologic confidence, definitive management, as well as a decreased need for close surveillance. However, I'd estimate that less than 10% of these small renal masses are benign on final pathology. So, however, I do acknowledge that a growing proportion of my referrals from other urologists have already completed a renal mass biopsy. As well, my average lesion size is approximately 3.8 centimeters. So we'd expect to have a lower proportion of benign pathology as the lesions are larger. As well, Hilar lesions carry a higher risk of bleeding or non-diagnostic biopsy due to their location. So my preference is to minimize these renal mass biopsy complications if I feel that nephron-sparing surgery is feasible. And we're fortunate at St. Paul's to have an excellent working relationship with our interventional radiologists, and monthly multidisciplinary rounds are beneficial in reviewing imaging as well as the management options for these complex lesions in patients. And so essentially, my most typical scenarios for renal mass biopsy are if one, there's a question of a lipid poor AML versus RCC. Renal mass biopsy is an excellent tool. For instance, this was a 44-year-old woman with a right renal lesion and with small foci of what appears to be macroscopic fat. The renal mass biopsy and subsequent partial nephrectomy pathology demonstrated grade 2 clear cell RCC. Second scenario is really higher stakes cases in which reduced renal function is a significant concern, and we prefer a confirmation of malignancy before embarking on a technically challenging surgery. Really, it's to assist with counseling in these medically and surgically complex patients. Ultimately, we should examine our own individual practices and centers to determine our own thresholds and indications for renal mass biopsy. But perhaps a simpler framework to follow is when a renal mass biopsy should not be performed. So they would include when there's lesions with abundant visible fat, which makes a diagnosis of AML on CT or MRI quite reliable, or in cystic lesions due to the low diagnostic yield, especially if there's no large solid component to it. And as well, when renal mass biopsy will not change the management, i.e. when active surveillance or observation or definitive management is going to be chosen irrespective of the biopsy result. So most importantly, patient preferences and values must be considered to facilitate shared decision-making about diagnostic tests and management. Some patients will prefer definitive management because they are just unwilling to accept any uncertainty after renal mass biopsy, or because they want to avoid a long period of imaging surveillance. In these patients, proceeding with definitive treatment would be recommended. So in summary, there are no imaging features that reliably differentiate RCC versus oncocytoma or lipid poor AML. Although the accuracy of renal mass biopsy is reported to be high, the lack of surgical pathology as a reference standard in negative biopsy leads us to an unknown false negative rate. There is a varying lesion in grade concordance that can be multifactorial, and this uncertainty exists in the reliability of renal mass biopsy to definitively triage patients. The non-diagnostic biopsy rate occurs in approximately 10 to 20%, and there are several factors that can influence this rate. Overall rate of complications from renal mass biopsy are low, although tumor tract seeding is likely underreported with unclear clinical significance. And we must review our own personal and center experience when determining whether renal mass biopsy alters clinical management. Thank you.